Mitja, it's very nice to see you again. Would you mind telling the audience something about your professional background, please?
Yes, certainly. Thank you to be here, Stephen. I'm a marketer for the better part of 20 years, a technology marketer. Recently, I've been working with Karger Publishers. I'm the head of marketing for Karger Publishers. I oversee global marketing for Karger. Karger is a Swiss publisher. We have about 100 plus reputable medical journals. We focus exclusively on health science, and we also have 9,000 books, and we work with the world's largest academic institutions and the world's largest pharmaceutical companies, but also smaller entrepreneurial enterprises in accessing knowledge, making knowledge visible and applicable.
Absolutely. Thank you very much for that. I might now introduce John Klepper. John, if you wouldn't mind telling the audience about yourself and how you ended up where you are today, please.
Yeah, sure. Pleasure to be here. Thank you, Stephen. Mitja, nice that you're joining us. My background, so I come from a very different field. Originally, I'm an artist, and I worked as a fine artist and then a filmmaker. And around 20 years ago, I got the opportunity to start my own company. And that gave me a little bit of a entrepreneurial bug. And since then, I've been founding, growing, and exiting different companies and projects in various different sectors. And about 8 years ago, I had the pleasure to sit with a neuroscientist who was working in Alzheimer's disease. And we started exchanging ideas, and I've always been very interested in brain health and physical health. And I don't know why, I'm just always in a field that was just super fascinating to me. And so we started to exchange ideas, and 3 hours later, he asked me if I wanted to start a company with him. And that was the beginnings of my embarkment in the medical field.
And it's been very successful, I must say, for someone who hasn't come from the field. Actually, that's probably a good credit to you that you haven't come from the field. So I guess the question is, you've begun PIPRA, P-I-P-R-A. Would you tell the audience something about PIPRA?
Yeah, sure. So maybe the origin story behind PIPRA. I was working for 2-3 years in Alzheimer's disease, also with a software approach using AI to predict and prevent. And along this journey, I started to learn about delirium, which I knew very little about. And the more I delved into the topic, largely through stakeholder interviews, but also reading medical journals, the more I was intrigued and curious, and also a bit shocked at just how big and widespread the problem was and how totally unaddressed it was. Being in the neurocognitive space, I became very curious, and around this time, while I was learning about this, I recalled my mother having told me a story of an experience that she had in hospital several years prior that was very traumatic and terrifying for her. So I called her up and I asked her to go back over and tell me again in a bit more detail what had happened. And essentially, she was describing delirium. So for the viewers who might not know what delirium is, it's a state of confusion, disorientation, can come with memory loss, and it can be very debilitating, can be very scary. for the patient, for the relatives. It's very often triggered by an event like a surgery, and particularly in patients who are, let's say, over the age of 60. And so as she began to describe this experience, I said, "Mom, you had delirium." And she had never heard the term, and she was never told what she had had. Luckily, she made a full recovery cognitively, because many don't, and we can talk about that later. But she ended up with kind of like a PTSD from the experience. When she goes near a hospital or even thinks about a hospital, she gets very excited. Her heart starts to race. She gets very anxious and doesn't want to go near a hospital, even when doctors say, you know, you should go get this checked, or you should, you know, she's terrified of hospitals. So then became like the personal motivation kicked in, and hearing how traumatic this was for my mother. Around that time, I met with one of my two co-founders, Nayeli, who's an anesthesiologist, and had been working in clinical practice for about 14 years. Her and I decided that this was something that we wanted to go into and look further. So we looked for some funding. And soon thereafter, we met our third co-founder, Ben, who is a scientist, cell biologist. And the three of us decided to go forward and to start a company and to devote our lives to trying to reduce delirium in the world. And it's wonderful to work with three multidisciplinary, very complementary founders, and to be working on something that's, you know, has the potential to have huge impact.
You've actually been so successful, you've attracted some significant awards. And one of them, of course, has come from Mitja's esteemed organization. Maybe, Mitja, you want to tell us something about that?
Absolutely. Well, first of all, we're very happy for PIPRA and for John, you know, in their fight, to be able to support them in their fight against delirium and the important work they're doing in their organization. PIPRA has been the winner of the Vesalius Innovation Award. The Vesalius Innovation Award has been put out by Karger now in the fourth year, and we are really awarding scientific startups or startups in the world of science that have really are centered around knowledge communication, artificial intelligence, AI, and patient centricity, which is really important for us. So these are the keywords. There's been, you know, obviously PIPRA has won the 2023 Vesalius Innovation Awards. And by the way, the name comes from Andreas Vesalius, a medieval pioneer of anatomy and 1543 author of De Humanis Corporis Fabrica. So we chose that name carefully. You know, but at Karger, for us, research doesn't stop in the lab. We're all about turning research into action through different ways. And for us, this is one of the ways how we are at the forefront of science and research and award these startups and companies and provide them with the possibilities to do further research and to succeed. And this is how we think of science and research, and we actively support that.
Thank you very much. John, I think that you've also attracted a number of other awards, and you're set up in some rather prestigious institutions currently. Could you tell us something about the institutions where the system is operating?
Yeah, certainly. So we're doing two different things in terms of getting our first product out into the market. Maybe just to talk a little bit about what the product is. So our first product is a risk prediction software. used for postoperative delirium. As I mentioned, the surgery can very often be a trigger for delirium. It affects 23% of patients over the age of 60. So almost 1 in 4 patients will experience delirium, which is quite staggering. And so this product, we have live in hospital in the United States, in Stanford, in Switzerland at the Hirslanden Clinic, and in Belgium, we're just now integrating into AZ Groningen. So this is just early days for us. We have several other hospitals that have expressed interest, and we're excited to be able to bring this solution to different hospitals. At the same time, we're also doing research to be able to both validate our software and collect more data for the next version of our software. So the software has been validated already with 2 external hospitals. It has been CE certified as a medical device, but we're continuing to validate it in clinical practice in hospitals in Europe, and we're going to be doing a clinical study in the United States as well. In Europe, we have 3 of the 5 major university hospitals that are currently doing a clinical trial with us, multi-centric study. So that's the University of Geneva, of Lausanne, CHUV, and University of Basel, or Unispital Basel. And then in Munich at the LMU Uniklinikum. So those 4 hospitals are generating a little over 1,000 patients worth of data for us to be able to do a further validation, but also collect, as I mentioned, collect more data for the second iteration, the second version of our software.
Okay, so from a layman's point of view, if I'm over 60 years old and I get a preoperative assessment looking for clues about the fact that I might experience delirium, is that part of the solution? And does it look at how the intraoperative solution, how the intraoperative treatment might affect my outcome? How does it work?
Sure. So essentially what we did is when you talk about AI, the algorithm itself is not the crucial part. There are hundreds of different algorithms you can pick to use, right? It's really about the data behind it. And building the algorithm was a very large endeavor. We did a worldwide systematic review. We did an IPDMA, individual participant data meta-analyses. We were able to gather data from studies that had looked specifically into delirium from all around the world and build an algorithm off the back of this very rich and very large database, one of the largest in the world, if not the largest. And how it works, to answer your question, essentially it collects risk factors. So these are typically routinely collected information from that's available in the electronic health record. A lot of this information is gathered during a pre-anesthesia consult. So if you had a surgery, for example, you would usually get scheduled to go see an anesthesiologist a few days before the surgery. They would ask you a number of questions. For example, what kind of medications are you taking? Have you experienced any, problems in the past? And they would write that into the EHR, the electronic health record. And then our software essentially sits in the back behind and extracts some of the variables, some of the risk factors, calculates that risk in real time, and then stratifies that risk into different risk groups from highest risk to lowest risk, and then writes that result back into the electronic health record on the main page of the patient record, so that all of the clinicians going forward can see, if they look at the patient record, this is a patient who is at low risk or at high risk or very high risk. So we run the algorithm, but we also support by providing automated communication to all of the stakeholders that need to know throughout the perioperative setting. So for example, nurses who are in the ward post-op. Very often in hospital, there's little to no communication that happens between pre-op, the anesthesiology team, for example, and the nurses who actually see the patients after surgery. So we work to improve that so that they know, okay, this is a high-risk patient. Further, what do we do if this is a high-risk patient? What steps do we take in order to prevent? So that includes online tools to learn, e-learning. It includes pocket guides and handouts so that they know these are the things that you need to be doing. And then we monitor all of that in terms of compliance to make sure that they're getting the treatment that they need, that that the nurses, for example, are screening correctly and often enough to see whether or not the patient actually got delirium. So this is all some of the things that we do to support the delirium prevention.
Would the anaesthetist see the report as well?
So they go about their normal job without any change. The only thing that happens is there's a score that comes up that says this is the risk for this particular patient. And that score, that risk, gets then written back into the electronic health record. So that's the only thing that changes from a normal routine clinical practice.
Okay. I think the important thing is about how a hospital pays for the system, how it's introduced into a hospital. Obviously, there's a training segment. How did you go about getting your system into the probably 3 of the finest hospitals in Europe?
So one thing that we typically don't need to do is convince the hospital of the need. Delirium is a problem all over the world in almost every hospital. As I said, it affects 23% of patients over 60. And it comes at a huge cost to hospitals because generally patients stay much longer in hospital. So in a recent integration here, for example, we saw the average length of stay was just over 4 days for their patients. And patients with delirium stayed over 9 days. So a massive difference in length of stay. And generally speaking, that means a big cost because every day that a patient stays, there's costs and overhead. Sometimes for private patients, they can make a little bit of money on a private patient who stays a bit longer, but it's very small in comparison to having a free bed and being able to do more surgeries and that kind of thing. So from a commercial perspective, the hospital wants the patient to come in. They want to have a good surgery, have a good outcome, and then go home happy and healthy, right? And we want to support that. And when a patient has delirium, the opposite happens. They stay much longer. They have a lot of complications. 38% of patients will end up with long-term cognitive complications like dementia. The risk for a patient with delirium getting dementia goes up 1,400%. The risk of them ending up in a nursing home goes up 600%. So there's lots of bad and negative outcomes for the patient, but also for the hospital. And what we do is we charge a very small pay per use fee to the hospital. So for that screening, and in the balance, the hospital saves millions through reduced nursing hours, reduced length of stay, reduced in-hospital acquired complications as a result of delirium, such as PTSD, falls, infections, reduced readmission rates. So there's lots of value that we bring to the hospital as well.
Where does the operation take you now? What pipeline are you developing?
We have a tool which is certified as a medical device, which allows us to screen for patients at risk of postoperative delirium. So we also want to build other tools to be able to improve outcomes and support the hospital and the healthcare system in general. And those include, for example, a home-based app where the patient or the relative, before admission to the hospital, can fill out some information. Some of that information will help us assess the baseline of that patient, what they're like normally. Do they have some pre-existing frailty or mild cognitive impairment, for example? This is information that is very helpful and vital to perioperative staff, who very often will see the patient for the first time and have no idea what their normal state is. So that's something that's in development right now. We hope to have on the market soon. And then we're also going to build a way to be able to diagnose delirium in a much more effective and efficient manner. So in other words, now the patient has gone through, did they actually end up with delirium or not? Today, 70% of cases are missed. And one of the reasons why they're missed is because diagnosing is a slow process and needs to be repeated every shift for several days. And the staff just typically don't have the time to do this. And second of all, because there's two types of post-op delirium. So there's the hyperactive delirium, which is usually very evident, where the patient might be screaming, pulling out their cables. They might be running through the halls naked, trying to hurt themselves or other people. So it can be very, very obvious and very traumatic. The other type is hypoactive delirium. And for a hypoactive patient, they stay very calm and quiet. And so there's a term that that is often mentioned in hospital, which is a quiet patient is a good patient, right? Because they don't take time. But when in the case of hypoactive delirium, the nurses, for example, don't realize that they might be having an extremely traumatic experience. They might be dehydrated, in excessive pain, having nightmares. Then nobody knows. And these patients typically get missed. They get sent home. And this can continue and often get worse and worse. And that's what we want to try to avoid. And then beyond that, we want to look into different types of delirium. So there's ICU delirium, there's medical delirium, there's all kinds of different types of delirium that we can look at. And then if we're successful in all these fields, in delirium, then we can move on to different types of neurocognitive disorders like dementia.
It's extremely exciting. I had no idea. I was very much aware of ICU delirium, but I wasn't aware of hypo or hyper. You may create new DRG and ICD codes, who knows? That would be great to change the language. That would be very important.
There are already quite a few existing ICD-10 codes. But, part of it is the tools that we want to bring, but it's also a large part of this is the awareness that we need to continue to build and raise. Because delirium is something that is starting to get talked about more, but not nearly enough. There are still far too many patients like my mother who are never told before surgery what the risks are, and never told even when they experience delirium that they're having a delirium. And so this is something that needs to change. And so, platforms like this to be able to raise awareness and spread awareness, and through Karger and the Vesalius Award, these are ways that we can help raise awareness and get the conversation moving in the right direction.
That's true. I'm quite aware of consent forms, and I actually know of several consent forms in a couple of countries where delirium is never mentioned. That's quite true. Okay.
And it's quite shocking because, you often get told about certain risks or complications that are tiny, less than 1%, 0.5% chance, of having some, a heart attack or something, for example. But something that has a 23% risk is just not mentioned.
True.
Which is, shocking.
And if I just may jump in here, I think John just said something really important. It's all about awareness, right? It's creating awareness for this disease, for this condition. I certainly never heard of it when I had to go to the hospital. I was simply not aware. So, and this is part of the reason why we have an interdisciplinary panel of judges that looks at our startups, and we felt that that was really a compelling technology that is very patient-centric, and patient centricity is very important to us, as I mentioned, and it deserves more awareness. And I certainly applaud John and PIPRA in their way to creating that awareness and helping patients with delirium.
Absolutely. Well, thank you both of you very much for your time today. I wish you both, I wish both of you great luck and good fortune. John, it's been fantastic to have you here. Mitja, I think that your awards have been obviously very insightful. And this particular platform is extremely exciting for a variety of reasons. One, I've actually experienced delirium post-operatively. And I can tell you it's a very unpleasant thing. I was hyper. That was when I was very young, but I'm quite familiar with this condition. And having worked in operating theatres and worked in recovery units, I can tell you I've seen it many times.
Thank you for sharing your own personal experience. I'd love to, perhaps offline, but I would love to hear more about what you went through, because this is one of the reasons why we do what we do. Why my team and I are so passionate about what we're doing is hearing these personal stories and, being able to do something about that, so that people who have experienced, but also others hopefully won't have to experience what you did. But what I was going to mention is that on Friday, I was at a conference in Basel, the Health Tech Conference. And we were also in a competition, which we also won. And after winning the prize, I went out for coffee to the coffee break, and 2 people came up to me that were in the audience and said, I want to thank you for what you just told us about delirium, because my mother had delirium and it was awful, terrible. She was suffered for 6 months. And then the other person said, my father had delirium and he died very soon after. And when he went into the surgery, he was fine. These stories we hear every day. It affects so many more people than we realize. And in fact, it's 60% more expensive to healthcare than diabetes.
That's an interesting number.
To give you a perspective of just how big this problem is. And so this is really what motivates us to do what we're doing. And yeah, I just wanted to thank you for sharing that.
Not at all. It's great to talk to you. How many in the team right now?
So we are 12 people, about 9 full-time, or FTEs, let's say. 3 founders, Ben, Nayeli, and I. And then we're supported by an incredible team of data scientists and researchers and product managers and developers, and it's really a wonderful team that you can clearly see the drive and the passion and the mission in everything.
Thank you very much for your time, gentlemen.
Thank you.
Thank you, Stephen. Thank you, Mitja.